Hi, and welcome to today's presentation on acute respiratory distress syndrome. Now, this is a type of acute diffuse inflammatory lung injury which is characterized by increased permeability of the alveolar capillary membrane with edema, loss of aerated lung tissue, as well as increased work of breathing and impaired gaseous exchange. What I'm trying to say over here is this condition occurs when fluid builds up in the tiny elastic air sacs or the alveoli of the lungs. Now, the fluid keeps the lungs from filling with enough air, which means less oxygen reaches your bloodstream, thereby depriving the organs of oxygen which they require to function. Now, we have two main, risk factors or causes of acute respiratory distress syndrome or acute lung injury. Now, we have the direct lung injury as well as the indirect lung injury. When we pick the direct lung injury, we have causes such as aspiration, that is, you may aspirate contents of the stomach into the lungs, which may cause, injury to the lungs. We also have pneumonia, then also toxic inhalation of some infectious, agents, and also near drowning trauma, which may even cause lung contusion. We also have the indirect causes, and the most common cause of indirect lung injury or acute respiratory distress syndrome is sepsis. Don't forget this. Now, example, you may have it, as secondary to trauma or, an infection or peritonitis or even bone marrow transplant, which is a major, surgery, and it has, with it a lot of, infection. We may also have it as a result of pancreatitis or massive blood transfusion, and also polytrauma, whereby there may be, multiple traumas to parts of the body, and the lungs or the thorax may also be affected, and also in fat embolism, which may be through a blunt trauma, and also in patients who are on medications such as the salicylic acids, and also some antidepressants such as the tricyclic antidepressants, and also chemotherapeutic drugs such as bleomycin. All these are factors which may, cause acute respiratory distress syndrome in patients. Now, let's quickly look at the pathophysiology of this condition. We have three main phases of the acute respiratory distress syndrome. And so if you look at the diagram on our right over here, this is supposed to be the alveolus. And as you can see, it is divided into two. We have the normal side, which I'm depicting over here, and the injured side. You can see the injured side is filled with, protein-rich, edema fluid. Now, the first phase of the acute respiratory distress syndrome is the inflammatory phase or the exudative phase, and it occurs between 24 to 48 hours of injury. And what happens is that the lungs are infiltrated by activated cells of inflammation, typically neutrophils. We also have the endothelia and the immune cells releasing cytokines. Specifically, we have the tumor necrosin factor alpha, as well as interleukin 1, interleukin 6, and interleukin 8, all coming to play over here. They all come together and cause, microvascular damage. As you can see, we have the blood vessel also surrounding the alveolus over here. Now, when there is, damage of these microvessels, it results in the leakage of fluid and plasma proteins into the alveoli and interstitial tissue, causing what we call non-cardiogenic pulmonary edema. It is non-cardiogenic because there is no cardiac involvement in this pulmonary edema. It is basically, the increase in permeability of the vessels as well as their damage, which causes the leakage of fluid from the vessels into, the lungs, specifically the alveolus of the lung, which cause this problem. And so we say this is non-cardiogenic pulmonary edema. Now, at the same time, when this is happening, the alveolar surfactants are denatured by the plasma proteins, and this will cause, or this will lead to the collapse of the alveoli. As we know, the surfactant helps, to increase the surface tension of the lung, and also helps the lung to, or the alveolus to expand. And so once they are denatured, as you can see over here, inactivated surfactant, once they are denatured, it leads to the collapse of, the alveolus, and this creates hypoxia as the fluid filled, the alveoli, and begin to cause, shunting of blood. Now, the shunt, or the moving of, the blood, is created when the lungs receive blood supply but are unable to oxygenate parts of, the tissues. And so in this case, there are diffusion barriers over here. So we have parts of the lung being perfused and others are not being perfused. Some are being oxygenated, others are not being oxygenated. And so there is barrier in the diffusion over here. Now, to worsen things at all, to make things so worse, there is further vasoconstriction and occlusion of the pulmonary capillaries by neutrophils, platelets, and fibrin. So as you can see over here, the vessels are occluded by, the neutrophils as well as the platelets and also fibrin. Now, when they occlude the vessel, it leads to areas of the lung that are not, or areas of the lung that are ventilated but not perfused. So you may have areas getting oxygen but not receiving blood. Now, alongside, there is also increase in the lung fluid, or the lung water, and so it causes the stiffness of the lungs. So as you can see, the fluid has risen up to this level. So there is, a stiffness or stiffening of the lung, which decreases its compliance, and this dramatically will cause what? An increase in the work of breathing. Now, this is only within 24 to 48 hours of, the lung injury. The second phase is the proliferative phase, which is between the second and the seventh day of the injury. And during these phase, or during these days, there is proliferation of the type 2 pneumocytes and fibroblasts, as you can see over here. So you can see the fibroblasts over here. So there is proliferation of them, they increase in number with the formation of hyaline membrane over here. As you can see, we have a hyaline membrane being formed over here. However, since these pneumocytes do not make any surfactant, the total production of surfactant decreases because they are not making surfactant, and the plasma proteins are also denaturing the available surfactant, and so we are going to have decrease in the production of surfactant, thereby exacerbating the loss of surfactant, caused by the denaturing of the, of the surfactant, and so we are going to have what? Further collapse of the alveoli. Finally, we reach the fibrotic phase, which is after 7 days. And during this period, the alveolar wall thickens owing to, disordered collagen deposition, as you can find over here, the procollagen. These are the procollagen. So we have a lot of collagen being deposited over there, and this deposition of collagen will lead to extensive, scarring of the lung, and this makes the lung stiffer and further increases the work of breathing. And this stiffening of the lung sometimes becomes so severe enough, even to make it very impossible for us to wean patients from the ventilator. Now, all of these processes come together to give us five main problems. And so there are going to be changes in these areas of the lung. We are going to have impaired gaseous diffusion because the alveoli is filled with fluid. We also have decreased lung compliance. We also going to have increased work of breathing. The alveoli is going to collapse eventually. Then we are going to have ventilation perfusion mismatch, which will eventually lead to hypoxia and respiratory failure in this patient. Now, it is important for us to know that not all patients will progress through all stages of this condition. This is because there may be resolution occurring along the line, but in most severe forms of acute respiratory distress syndrome, almost all patients will progress to the fibrotic phase. And so how do they present? We have the respiratory system exhibiting signs of labored respiration or breathing. There's going to be tachypnea. Upon auscultation, we are going to also hear diffuse crackles all over. Then we are going to see the patient cyanosed because he's not receiving enough oxygen. Another cardiovascular system, we are going to find sweating as well as tachycardia. And the patient is going to be agitated. And this will lead to lethargy and decreased level of consciousness in this patient. Some or most of these patients may cough, may have fever as well as chest pain. Sometimes also we may find patients who are having very low levels of oxygenation, having bluish lips as well as nails. This is a very typical sign indicating severe hypoxemia in the patient. So how do we diagnose this patient? Now, the diagnosis is based on the onset of hypoxemia as well as the bilateral chest opacities that we find on the X-ray, but we must make sure that there is no cardiac involvement. And so with our laboratory studies, we shall go for the arterial blood gas. Initially, we are going to find hypoxemic respiratory failure with a reduced partial pressure of arterial oxygen. We are also going to find respiratory alkalosis, which may lead to the ratio of partial arterial oxygen and the fraction of inspired oxygen being reduced or less than 300 millimeters per mercury. The other findings may depend on the underlying cause of the acute respiratory distress syndrome. And so we may find, for example, in sepsis, an increase in WBCs, and also if there are renal involvement, we are going to find an increase in the creatinine levels of these patients. Now, with our imaging studies, we may use both the chest X-ray as well as the CT scan. Now, when we pick the chest X-ray, what do we look for? We are looking for diffused bilateral infiltrations on the lung, or what we call the perihilar bat wings or butterfly distribution of the infiltrates on the lung. And since we said surfactant is reduced in its production, we are going to have collapse of the lung or atelectasis on chest X-ray, and also pleural effusion as well as air bronchogram. Now, we may also use the ultrasound as well as the CT scan in the diagnosis of these patients. Now, with the ultrasound, it's important for us to use the ultrasound because it helps us to or it even provide alternative instrument in monitoring and also recruitment efficacy of the lung, and it helps us to also rule out pneumothorax as well as the follow-up of pneumothorax after pleural damage. Now, it is also good to use, ultrasound, because it saves the patient, or it saves us from, transporting this patient, such a critically ill patient, from bed to the X-ray department, and also even exposing this patient to all these, amount of radiations. And so it is important for us to adapt the use of lung ultrasound in the diagnosis of acute respiratory distress syndrome. Now, how do we differentiate other conditions from acute respiratory distress syndrome? As we've seen, cardiogenic pulmonary edema is the most important of all the conditions we need to differentiate. And how do we differentiate this? Usually, cardiogenic pulmonary edema presents with signs of cardiac dysfunction. And so, when you auscultate this patient, you may find, or you may hear murmurs, and you even see jugular venous congestion upon inspection. Also, cardiogenic edema is usually characterized in its first stage by observing septal lines on the chest X-ray, and these are usually more visible in the costophrenic angles of on the chest X-ray, and also prominence of the upper lobe vessels in such patients. We may also use the B-type nitriuretic peptide to help us differentiate between cardiogenic pulmonary edema as well as acute respiratory distress syndrome. Now, any BNP or B-type nitriuretic peptide, which is more than 500, may suggest that heart failure is not, heart failure is likely, and any BNP which is less than 100 may suggest that heart failure is unlikely. So they may, if the BNP is less than 100, there may be no cardiac involvement. Then we can also differentiate acute respiratory distress syndrome from Trally and Taco. What do they mean? When we say Trally, we mean transfusion related acute lung injury. Now, this is a severe complication of blood transfusion, and it usually, occur, when we transfuse this patient with blood, and usually we have, leukocyte antibodies in the transfused plasma of this patient, and because of this, it leads to agglutination of these leukocytes, as well as pooling of granulocytes in the patient's lungs. And when this happens, it will result in injury to the cellular membranes as well as the endothelial surfaces, to damage the endothelial surfaces, and so it will make it more permeable for fluid to leave the endothelium to the lung tissue, and also it may even damage the lung parenchyma itself. And so we should be able to differentiate between this and acute respiratory distress syndrome. Then the next one being the TACO, which means the transfusion associated circulatory overload. This condition is usually a transfusion reaction that occur due to a rapid transfusion of large volumes of blood to a patient, and this, because we are transfusing large volume, it leads to hypervolemia, and usually patients may exhibit symptoms of acute respiratory distress syndrome. So there are a lot of conditions that we may differentiate between ARDS and ARDS and them, but these are not exhaustive. There are a lot of them, but these are the most important ones I think we can talk about. Now let's look at some chest X-ray findings. So in this chest X-ray, as you can see, when the patient came, on admission, we didn't find any pathological changes on the x-ray over here, this x-ray, we didn't find any pathological changes. But on the next day, there were some pulmonary consolidations which appeared at the lower lobes of the x-ray over here. As you can see, we have some pathological consolidations over here, some infiltrations taking place over here. Then on this one, we found diffused alveolar involvement with white lung appearance. So you can see there is diffused involvement of the alveolus over here, filled with fluid like that. Then on the last there, if you look at this diagram, you can see there is almost no lung tissue seen over here. Everywhere is filled with fluid, but we can see that the normal size of the heart and its vasculature is permanent. So it even helps us to differentiate between cardiogenic pulmonary edema as well as acute respiratory distress syndrome. Now, when we look at this diagram, also you can see there is almost this part of the lung is almost collapsing over here, as you can see, and over here you can see a lot of infiltrates all over here. On this diagram, you can see a lot of infiltrates, almost showing like a bronchogram over here. As you can see, so many infiltrates, all over the lungs. Then we have on this one, as you can see, the air bronchogram over here, very nice showing over here. Now on CT, what we find is that we have non-homogeneous distribution of the infiltrates all over the lungs, and we have a more dense consolidation in the dependent regions. So you can see you have a more dense consolidation over here, which is spread. It has spread all over here and forms the ground glass opacities. So you can see all these opacities over here. You can see some also over here, and also you can see that the interlobular thickening of the lungs, you can see them over here, how thickened they are. Here too you can see thickening of the interlobular membranes. Then we also have pleural effusion, also happening over here on CT. Now how do we go ahead to diagnose this patient? Even though we've seen the diagnosis, we need to follow some criteria to help us in our diagnosis. So we follow the Berlin criteria for diagnosis acute respiratory distress syndrome. Now, it says we must have hypoxia, which is defined by the ratio of PaO2 and FiO2 less than 300 millimeters per mercury. Then also bilateral infiltrate on chest X-ray, and we must rule out the non-cardiac involvement, and so our pulmonary capillary wedge pressure must be less than 18 millimeters per mercury. Now, how do we come by the PaO2 and FiO2 ratio? Now, let's do some mathematics over here. As we know, PaO2 is the partial pressure of arterial oxygen, and the normal being 80 to 100. We also have the FiO2, meaning the fraction of inspired oxygen in the air. So this is the air that we breathe. The air that we breathe, the room air, we have approximately 20% or 21% of oxygen in it. So with this knowledge of fraction of inspired oxygen, we can approximate the partial arterial pressure of oxygen by multiplying the FiO2 by 5. And so if we have 20% as the fraction of inspired air, that's the air we are breathing, multiply by 5 and we get 100. So partial pressure of arterial oxygen over here is going to be 100 millimeters per mercury. Now, importantly, the fraction of inspired air is expressed in fraction, and so the 20% will be 0.20. Now, in acute respiratory distress syndrome, we give supplemental oxygen, and this supplemental oxygen may either be through the nasal cannula, the ET tube, or even through the mask. And so these patients receive extra oxygen in addition to the normal room air that they are breathing. And so the normal room air is 20%. But during acute respiratory distress syndrome, we give them extra oxygen. So, how do we calculate this fraction of inspired oxygen? It's not difficult. I'll show you. Look, you look at the flow rate. All of these patients may be on oxygen, and you look at the amount of oxygen they are receiving at a time. Sometimes it may be 2 liters per minute, 3 liters, 4 liters, or 5 liters per minute, whatever the liters per minute. Pick the amount of oxygen they are receiving in liters per minute, then multiply by 4. Now, the answer you get, you add it to the room air that the patient is breathing. This is because they are receiving extra air. And so if the patient already is breathing 20% of oxygen and we are giving supplemental oxygen through face masks, ET tube, or nasal cannula, it means we have to add the two together before we can get the fraction of inspired oxygen. So let's look at an example. For example, if the patient is receiving 6 liters per minute as oxygen, then we have to add this 6 liters per minute. We have to multiply 6 by 4 to get 24. Then we must add it to the already room air that the patient is breathing, which is going to be 44. And since I said the fraction of inspired oxygen is expressed in fraction, 44% is going to be 0.44. Now, based on this, we can classify acute respiratory distress syndrome into 3 based on the ratio of PaO2 and the FiO2. Now, we have the mild, moderate, and severe. Any ratio of PaO2 and FiO2 between 200 and 300 is regarded as mild, 100 to 200 is moderate, and less than 100 is severe. Now, we are going to look at how to get the fraction or the ratio, but let's do this with a clinical presentation. For example, a patient with chronic hepatitis or chronic pancreatitis, with complaints of shortness of breath, purulent sputum, heart rate of 105 beats per minute, temperature of 38.3, blood pressure of 120 over 60 millimeters per mercury, and oxygen saturation of 80. Now, this patient is on oxygen mask at a rate of 5 liters per minute. Chest x-ray reveals diffused infiltrates, and arterial black gases also shows partial arterial oxygen of 60 millimeters per mercury. Remember, the normal is 80 to 100 millimeters per mercury. Let's diagnose and classify our answer. You can pause it and try it yourself. Now, since already the patient is breathing 20% of room air or 0.2, the supplemental oxygen that we are giving is 5 liters. And so we multiply 5 by 4 or 5 by 0.04 since we express it in fraction. The answer that we get, we add it to the room air that the patient is breathing, which is also 0.20. And the answer that we are going to get is 0.4. So the fraction of inspired oxygen is 0.4. That is the amount of oxygen the patient is breathing plus the room air that the patient is taking in. Now, since we know our fraction of inspired oxygen, we quickly have to just divide it by the partial arterial pressure of oxygen, which is 60 millimeters per mercury. So we divide 60 by 0.4 and we are going to get 150 millimeters per mercury. And so quickly we just go to our chart and we find that 150 is between 100 and 200, and so this patient is having moderate acute respiratory distress syndrome. Now, an important thing I want you to note over here is that the higher the fraction of inspired oxygen, the worse the prognosis or the worse the condition. What it means is that the patient is requiring, or the patient requires more oxygen or more supplemental oxygen in order to maintain saturation, which is bad. And so when we reduce the fraction of inspired oxygen, the patient condition is going to deteriorate. So the patient requires more oxygen before the patient can maintain saturation. And we don't like it like that. Also, the lower the partial arterial pressure of oxygen, the worse the prognosis or the bad the condition. This is because this means that the patient is not receiving enough oxygen, or the patient is not getting enough oxygen delivered. So both conditions may be bad. So we don't want to give the patient a high fraction of inspired oxygen, and we don't also want the patient to be on a low partial arterial pressure of oxygen. So this is all that I have for you today. In our next tutorial, we are going to discuss how to manage a patient with acute respiratory distress syndrome. Thank you very much for your attention.